Hang on. You look wired. How about a nice canvas? Can I just double check everyone can see my presentation? If somebody can just give me, I can't see anyone's face, so if somebody can just say yes. Oh, lovely. Thank you. Thanks, Rahul. Thanks, Sarah. Sorry, is your hand up, or was it just to give me the confirmation? I presume it's just to give me the confirmation, so thank you for doing that. So first of all, thank you so much for joining us this evening for our monthly community pharmacy open house surgery. If you're new to this and it's your first time joining, first of all, really warm welcome to you all. Thanks for joining us this evening. We do this, well, me and my team, we do this every month. It occurs on the third Wednesday of every month, and it's an open house surgery. It's what it says on the tin. Every month we bring to you some LLR specific relevant news that may be affecting community pharmacy. And tonight we've got some great presentations from our colleagues, and I'll do some introductions shortly. But this is if you want to watch any of our previous open house surgeries, they are also on our website as well, and I'll put that link in the chat afterwards as well for you. So if you want to look at any of the previous presentations or listen to them, please feel free to do that. So let's press on. Okay, just before I do the agenda in terms of what we're discussing, we do have a social media community that's really hitting the ground and gaining a lot of traction. We're on Instagram, we're also on LinkedIn, so I know some of you do get already my emails, and if you don't, please do let me know in the chat by adding your email address, and I can get you added onto that shortly as well. Just something I'm finding as well is that when I'm speaking to a number of contractors, community pharmacists, locums reliefs, they're not really aware of some of the WhatsApp groups that we've already set up as Community Pharmacy Leicestershire and Rutland to support community anybody working in community pharmacy as well. So if you want to be part of we've got two WhatsApp groups. So the first one is contractor based, so please do drop me a message on WhatsApp, and my mobile's right there at the bottom, 07984 465 387. And the second WhatsApp group that we've got available is for locum specifically, and you'll often see me post on a daily basis just in terms of relevant information, deadline reminders, and what you really need to know in order to keep going and working within the sector as well. So conscious of time, we only have an hour today, but we've got a really great agenda tonight, but we also want to hear from you, from those of you that are working within community pharmacy and our contractors as well. Tonight we've got Dr. Anna Murphy, and I'm really delighted that Anna's here. I've been working with Anna now for nearly 3 years. Anna is a consultant respiratory pharmacist at UHL. She's going to be talking about the changes in terms of the LLR asthma guidelines, which have been shared with you all over the last couple of weeks as well. Delighted that Paul's joined us as well. So for those of you that are regular will know that Paul is our ICB Community Pharmacy Clinical Lead, and he'll provide just an update in terms of what we need to know as, from his perspective, and obviously give us an update with some of the pilots that are running throughout LLR as well. And then that will be followed by me, just a very, very quick update in terms of Chief Officer update within LLR, any national news as well. And then I guess the most important thing is that we want to hear from you, the contractors, our pharmacy teams, your feedback, just to help us keep our ear to the ground. So that said, Anna, can I come to you, and I'll just stop sharing. And if you want to share your screen.
Yeah, I will do that.
No
can
problem.
You see my slides?
We can just see your blue screen, your desktop at the minute.
Oh, can you? That's not good then. That's not what we want. Probably because it's on.
There we go. We can see it now. So it just needs. Yes, it's when you've got too many screens open.
That's the problem.
I did that. That's brilliant.
Okay.
So Anna, over to you. Thank you.
Lovely. And yeah, sorry.
No, I was just about to say, if anybody has any questions, feel free to pop them in the chat. I will be monitoring the chat as well, and there'll be obviously the opportunity to ask Anna any questions at the end of her presentation.
Absolutely.
Thanks, Anna.
Yeah, no, thanks, and thanks so much for squeezing me into your agenda, and it's great to be here, and it's great to have the opportunity to give you a bit of an update, because I feel that we have made some changes to the asthma guidelines, and these are adult asthma guidelines, and I'm really keen to have your support and to make sure that you're aware, and you may get patients asking questions, and I want you to be prepared to be able to support those patients, and also for your own learning. So for those that don't know me, I'm Anna Murphy. I've been working in respiratory across LLR for many years now, and still very passionate to support the role of the community pharmacist. It's incredibly important what you do for our patients. So I'm just going to give you a very quick update. Not going to spend a lot of time. I'm not going to do a talk on asthma, but I do think it's really important. The reason why we've changed the guidelines is to try and get this message across that asthma is an inflammatory disease, and really the only treatment for treating asthma is a treatment that will reset a person's immune system and to reduce the inflammation within the airways, and as such that is an inhaled corticosteroid. So we have got to get away from the fact that so many of our patients continue to over-rely on using their salbutamol inhaler, and we still see far too many of our patients only treated with salbutamol when they have asthma. If it truly is asthma, then you would expect to see a patient on an inhaled corticosteroid, because that really is the main treatment for their asthma. This has been very much taken up by GINA, which is the global strategy for asthma management, okay, GINA. And basically, they've changed the strategy that salbutamol does not treat the asthma inflammation. In fact, salbutamol has been shown to increase inflammation within the airways, and that salbutamol monotherapy should not be prescribed. Therefore, all our patients, as they should, be on inhaled corticosteroids. And GINA introduced really pushing sort of MART therapy, maintenance and reliever therapy, but also introduced air therapy, which I'll explain what that is in a moment, which is anti-inflammatory reliever therapy. Okay, so it's really saying we should no longer be using SABA on its own, and really ideally not using salbutamol inhalers as much in people with asthma at all. The other aspect that we need to try and deal to sort of address really within LLR is our prescribing according to the green agenda. And as you know, and you've heard many talks about this, metered dose inhalers contribute somewhere between sort of 3%, 4% of our greenhouse gases generated within the NHS. And unfortunately, within LLR, we are very high users of the metered dose inhaler, which is not good for our environment, but also for me, many of our patients cannot use their MDIs as well as they should. So many patients breathe in far too quickly, tends to hit the back of the throat, and the lung deposition is reduced drastically. So we wanted to think about what can we do within LLR to think about the new GINA guidelines, think about how we prescribe according to the green agenda, and to update our adult asthma guidelines. Like I said, we're not doing particularly well, and these are just some of the figures where, we are not prescribing according to our sort of guidelines, and, SABA prescribing is high, but I'm not going to concentrate too much on these are the meds optimization targets that we're looking for within LLR. Let's get to the nitty-gritty of what the guidelines are. And as stated, these were sent round to you very kindly, so you've had a look at these guidelines. You can see just by glancing at this, and I'll go through in more detail, but you can see there's a flexible regime and our more traditional regime, and that's because some prescribers may not want to go down the flexible regime, or some patients won't. So we've got to have an option of both, and also there's many of our patients who are already on the traditional regime, and it's good to know where they fit really with the flexible regime. The first three boxes are really primary care prescribing, and this red box here is really where patients are on high dose inhaled corticosteroids, and these are the patients that really should be under secondary care. And really what I'm going to focus on mainly is the first three boxes with you this evening. So let's have a look in a little bit more detail. On the back of the guideline, there's this is what it looks like. So there's a lot more information, and again, I'll go through that very briefly with you this evening. So this is the flexible regime, okay? And really what this is trying is to try and remove the salbutamol element to stop people over relying on their salbutamol inhaler. So the air is the anti-inflammatory reliever, and basically this is for very few patients, but those that perhaps have asthma symptoms less than twice a month. And instead of those patients being given a salbutamol inhaler and told to go away and use that whenever they need it, they will be given a dry powder inhaler that contains formoterol. And the devices that you can see across the board, our first line is the Fobumix Easyhaler, the Foster Nexthaler, or the Symbicort Turbohaler. And we're very much trying to push the increase in the Fobumix Easyhaler, which is the most cost effective and in fact a very good and easy inhaler for patients to use. So I'm very keen to make you aware of that, because you may find that you start seeing a lot more prescriptions for Fobumix as time goes on, and I just want to make sure that your stocks are or you're prepared for it. Now, I have been in touch with the wholesalers. They are aware that our guidelines have changed, so again there should be stocks available for you, but please let me know if there's any problems with stocks, and I can put pressure from the company point of view as well. Not all patients will be able to use dry powder inhalers, and therefore there is an alternative, an aerosol alternative, but this should be a second line. And we are switching, sorry about this, but from Foster MDI to Lufabec. And I'll be very honest with you, this is just a cost-effective intervention for the ICB, saving up to, I think, £2 million if 100% switch from Foster MDI to Lufabec. So it's a considerable amount of money, and it's just a branded generic. Okay, but going back to air, what basically patients will do is they just use it whenever they get symptoms. So they have one dose when they require, and it's based on the licensed dosing, which is in the bottom box on the right there along the bottom. Okay, but as I said, the air is for very few patients. What we were more likely to see is MART. And I think you're all very familiar with MART. We have patients on MART, but we wouldn't normally start it so early on the treatment algorithm. Normally you would see like QVAR 50, 2 doses twice a day with salbutamol PRN. But we're not advocating that now. We're advocating going straight for an ICS-LABA combination inhaler, first line Fobumix, okay, and then Foster and Symbicort and Lufabec. And that's where patients will use it twice a day, but if they need extra, they will have it. And that's so that they actually get an extra dose of inhaled steroid, which will help to reduce the inflammation in the lungs rather than just over relying on salbutamol. And then if they get more symptoms, they can then step up to the 2 doses of the Fobumix or and so on. So they can go between the green and the purple boxes according really to their symptoms, and we can step patients up and down quite simply. Montelukast is still there, but please be aware of the MHRA guidance and the risk of nightmares and sleep disturbances. And we probably are beginning to use Montelukast less for our patients. Spiriva is there, but very few asthma patients actually do respond to Spiriva. It works better in patients with more fixed airways disease, such as those with COPD. So that's a big change, I think, to the asthma guidelines. It's this air and MART very much pushing the ICS-LABA. Just to let you know that the regular traditional treatment, as I said, is there. We haven't changed a great deal the medications within that. I mean, Fobumix has been part of our guideline in the last one, but we're probably trying to encourage it more first line now, and definitely pushing this dry powder because of the green agenda. Okay, so those are the changes. Obviously, Lufabec again is a replacement for Foster MDI, so regular and regular medium dose, and that's probably more akin to what you're used to seeing. But this SABA monotherapy is something that we're trying to remove from our asthma guidelines altogether. We know that reviews are really important. This is what we're sort of saying to primary care, to make sure that we are reviewing patients and stepping up and stepping down treatments accordingly. And that's just some information there. And this is some of the information that depending on where patients sit, if they're having more than 2 courses of oral steroids, that is now a red flag. And we would expect patients to starting to be referred from primary care to secondary care, because we can start injections, the biologics now for asthma, if patients are having 3 or more courses of oral corticosteroids in a 12-month period. Those are the type of patients that we are being lined up now for biologic treatment to try and reduce the risks of oral steroids. So really thinking about patients that are uncontrolled and stepping up their care is really important. And a lot of this primary care stuff, the smoking cessation, thinking about physical activity, weight management, all areas that I know that some of you have been involved in and are involved in, which is fantastic. And of course, from a pharmacy quality standards point of view, there are still aspects of the PQS that you are involved in from an asthma perspective. So this is a sort of patient, 3-month history of intermittent cough with breathlessness, no history of asthma or childhood asthma. This is a patient you might sort of see that they've been having courses of steroids. They've got wheeze on examination. If you could see, their blood eosinophil counts are often raised, which is a mark of inflammation. And you may see these patients going straight on to MART. And obviously we want to get a proper diagnosis, and diagnosis is important before we start treatment, and spirometry is still recommended for the diagnosis of asthma. But you may start seeing these sort of patients coming through and you think, gosh, they've just been started on ICS-LABA. This is actually almost what we're wanting to do, starting at this green box here. We would start with deep dry powder technique. Particularly all new patients should be started on a dry powder if they're able to tolerate it, and this is where you get the Fobumix being seen. It's a nice little device for patients to be able to use. So the new formulary, Fobumix Easyhaler, really now being used as first line. So you will see an increase in the 164.5 Easyhaler. The Foster MDI, the switch to the Lufabec, which is the branded generic. And another change you also see is we've actually changed from Aero Chamber Plus Flow View to using the Easy Chamber. And again, That's a cost initiative that we have to take on board within the ICB. So all UHL, LPT, and primary care on board with these switches, and have all gone through the ICB. There are action plans, and there is a action plan for LLR being developed, but there are the Asthma and Lung UK ones that patients may have, so you may see these. I'm not going to go through these in detail today because we haven't got time in the 20 minutes I've got. There are a few things I want to just go through very quickly. These are sort of questions that I get asked all the time, and it's likely that you may want to ask me these questions, or you may find that patients ask it or it comes across. So these are just the common ones. So I'm just going to very quickly, don't worry, I won't take up too much time, just go through these questions because I think these are the ones that you might find are important. So generating enough inspiratory flow for DPIs. The answer is yes. Patients can. So actually dry powder inhalers require very little inspiratory flow. And even patients with COPD, you think, oh gosh, they won't be able to do it. They can. COPD and asthma really is often where they have trouble sort of breathing out. Inspiratory flow is often very easy for patients to do unless you've got very severe COPD disease. Okay, most patients can do the 30 litres per minute. And if you think about when you can't breathe, you want to try and get something in. So quite often that quick and deep inspiration that asthma patients have actually fits very well with a dry powder, and less so with an MDI, where you need a very slow and steady inspiration. So it's an internal sigh with an MDI, and that's why a spacer is so important, because if you don't use a spacer, you tend to breathe in too fast and it hits the back of your throat. Unfortunately, many of our patients don't use spacers or won't carry them. So, actually DPIs often work quite well with our patients, and there's lots of different studies, but if we look at the Easyhaler, 30 litres per minute, success rate across most of the studies is 97 to 100%. Okay, so very good success rates in patients being able to use the Easyhaler device, and likewise with the Nexthaler. The Turbohaler perhaps a little less, but actually the lung deposition from a Turbohaler is high, so that sort of compensates for patients having slightly less inspiratory flow. So patients may not like DPIs, and I address that in a moment, because it doesn't feel like the drug is hitting the back of the throat. So when patients switch from a MDI to a DPI, they say, oh, I don't like it, I don't feel I'm getting it. And what we need to tell our patients is the fact that they don't feel it is good, because it's getting in the lungs rather than hitting the back of the throat. Okay, and it's more about how they feel clinically rather than the feeling. Some of the dry powders cause taste. So Nexthaler has a sweet taste. Some people like it, some people don't. So it's just dealing with that. What do we do during acute exacerbations? Well, again, Gina is very clear on that, and the evidence is very clear that actually patients can use dry powders even during acute exacerbations. If they're not able to generate enough inspiratory flow to use an inhaler, then actually they should be in hospital, because they actually aren't generating enough air through their lungs. And if you think about it, most patients are able to breathe in during these times, and if they're that severe, they are in hospital. Some people will say, well, do they need an additional MDI and spacer just for those occasions? No, we're not advocating that. They should be able to use their DPI okay. We use formoterol instead of salbutamol because it's got a very good dose. We can use it instead of salbutamol, should I say, because it's as quick acting as salbutamol, acts within 1 to 3 minutes. The good thing though, formoterol keeps the airways open for 12 hours rather than 4 hours with salbutamol. And actually, with us as pharmacists being a little bit geeky, it's a full agonist compared to salbutamol, which is only a partial agonist. So you get an excellent dose response from 6 to 72 micrograms, which is why you can use it PRN. Salbutamol actually is very flat, and it is thought that if you fill all your beta-2 receptors with salbutamol, you'd still only get 40% clinical efficacy because of that partial agonist effect. Okay, so it's actually not a particularly good drug, salbutamol. It works quickly, patients love it, but actually formoterol is a much superior drug, and therefore using ICS LABA as MART or as AIR, getting rid of the salbutamol has a much better safety effect and efficacy for our patients. The other thing I wanted to say is that high dose inhaled corticosteroids should be reserved to secondary care. And that's partly because actually most patients don't even need high doses, because low dose inhaled steroids and the medium dose actually have about 90% clinical efficacy. And that's in terms of FEV1, peak flow, rescue medicines, and there's more data on blood on sputum eosinophilia and also exhaled nitric oxide, all showing that inflammation is controlled with low and medium dose, and the higher doses doesn't offer very little advantage in terms of reducing inflammation. But as you can see from this graph, the high dose, you can see adrenal insufficiency, cataracts, vertebral fractures and diabetes, all linked to high dose. And remember, high doses patients need to carry an emergency steroid card. So wherever possible, we need to ensure patients are adherent to low and medium dose and have a good inhaler technique to support them in using that. Like I said, many patients will say they don't like dry powders. I think what I'm trying to say to the prescribers is make sure they feel confident with dry powders, because if you don't come across as being confident and saying that these are going to work as well and teaching patients how to use the technique, then that may come across with the patient. It's important though that the decision is shared with the patient. So if they really aren't going to use a dry powder, then that's absolutely fine. The aerosols are there as a backup. You may have had patients say to you, I need Ventolin and I can't have Salamol. And I hear that all the time. And I'm not sure if that's a Heinz tomato ketchup branded snobbery, which I personally have as well, or is it the fact that they don't feel it works as well? But one of the reasons is that Salamol has a much slower velocity, so it impacts the back of the throat less than Ventolin. And actually, that's a good thing, because it gives patients more time to breathe in and have that slow and steady breath in. So it's just trying to explain that to patients. Patients changing from Foster to Luforbec, okay, from other areas, and this is really important for you to take on board, because I don't want you to have all the patients complaining to you about they've switched me to Luforbec, it's only because of the cost and blah blah. Well, unfortunately, it is because of the cost, but it shouldn't make people cough. What we need to do is encourage them to breathe in slower and steadily. Often, if they breathe in too fast, that's what makes them cough, or encourage them to use their spacer device. Or if it really is making them cough, then the alternative is to change to a dry powder inhaler, okay, because they probably are breathing in too fast. So it's that if you want to get it down, slow it down. That's what we need to, almost the message we need to give people with MDIs. And Luforbec may make people cough if they breathe in too fast, okay? So it's a technique sign, which is quite helpful in a way, because it means that they're not using it right. The other thing that's just quite useful with MDIs is if they are getting cramps or tremor, anxiety with salbutamol, it's also a sign that perhaps their technique isn't as good, and it could be a way to lever to DPIs or improve their technique. So just to sort of summarize, yes, most patients can use a dry powder inhaler. If you've got acute exacerbations, that they don't need a separate MDI and spacer, they just need to continue to use their dry powder, ideally with a personalized asthma action plan. I know some of you in the past we've used in-check dials, and when I do my training, I would still use in-check dials, partly because it's useful for an MDI assessment to show people how slowly they need to breathe in. Do you need it for a dry powder? No, not necessarily. Just get someone to do this. Okay, and if you can see them drawing the breath in, they've got plenty of the air. And things like the Nexhaler will click if they've used it. If it doesn't click, then no, they can't use it. So just, they might need encouragement, or they need to change a device. But most people will be able to use the devices. Remember, in countries in Scandinavia and a lot of Europe, they use nearly all dry powder, and they have actually better outcomes than we do. So we shouldn't be too worried about this change from a MDI to a dry powder. Can we use formoterol instead of salbutamol? Yes, absolutely. We've been doing that actually for years. We're just pushing it a lot more now. Dose of ICS, if you were prescribing or monitoring, we should be trying to courage the low and moderate doses. Patients don't like dry powders. I think it's the key thing that if you're handing out a dry powder and it's a change for that patient, just explain to them, I know you haven't got a huge amount of time, but that it will feel different, but that's not a bad thing. That's actually a good thing that they don't necessarily feel it. Okay. And is it all about the money? Well, come on. I mean, we have to we have to use NHS resources as best as we can. Believe you me, I would fight for my respiratory patients if I felt we were giving them a done deal. But I really don't think we are. I think we are still giving them the best treatment that we can, but we will save money for the ICB, which then hopefully can be used in other resources and benefit our patients differently. I think what we're wanting to try and do is ensure that every dose counts. So optimizing inhaler technique is essential, reducing SABA prescribing to reduce harm and risk to our patients. Reduce high dose inhaled corticosteroids. Eventually, we need to tackle that across the ICB. But this is all about leading to improvements in patient outcomes and not just about saving money. Okay. But I am not going to hide the fact that we are, if we do this right. Okay. And that's really all I wanted to say. There's a lot of supporting resources on the LPC website. If you go onto respiratory, LLR, APC, there's lots of information there. There is a project ongoing within the or about to start, should I say, across the ICB, where they will be encouraging patients to agree to switch. So I can tell you more about that another time, but it's all about trying to promote the dry powder and Fobumix for our patients. Okay, so I hope that hasn't taken up too much time. I will stop sharing my slides now, if that's okay.
Thank you, Anna. No, you haven't taken up much time, so we're okay for time. I'm just going to ask if anyone has any questions, so put your hand up. I know Ali has asked a question. If I can just present that to you, Anna. Why does Montelukast have to be given at night? Can it be given at any other time of the day?
Yeah, so it's a really good question. I I mean, Montelukast, as you know, has been around for a number of years now, and I think the original studies were it was given at night because traditionally patients have a morning dipping, so their asthma first thing in the morning is often less, and you see a reduction in peak flow. We always used to call it the morning dips. So it was felt that if Montelukast was given at night, then actually it would help to prevent that morning dipping. Yeah, to be fair, that's just become a tradition, and most patients will take it at night. But if a patient, doesn't want to take it at night and finds it easier to remember to take it in the morning, to be honest, it's absolutely fine. It's not going to cause drowsiness. It's just because of that morning dipping, and it's got a good, 24-hour mechanism of action, so it shouldn't make any difference at all.
Thank you, Anna. Are there any questions for Anna? I mean, I've, feel free to raise your hand. I'm happy to ask them as well. Paul, let's bring you in.
Thanks. It's not a question. It's just a point and a reminder, really, that everyone in the ICB is really keen to see patients who have inhaler switches to be supported via the NMS. So do please look out for those patients when they've had a formulation. Even if it is a formulation change, we actively encourage an NMS in those situations because we recognise that patients need to have that sort of that constant feed of the message. So absolutely do take the opportunities there to support patients when they've had an inhaler switch, even if it is just a formulation change from MDI to dry powder, and even the brand is the same. We actively encourage it, and it's not a problem. Please go and do the NMS.
Yeah, absolutely,
Thanks.
Paul. And I should have put that on my slide because that is definitely what we're telling all prescribers and primary care to utilise your skills as a community pharmacist, and also from a discharge medicine service as well. We're also trying to promote that much more and trying to make some notes to you so it's very clear exactly, that they have been switched or what's been changed. So yeah, absolutely. Please use this as an opportunity to increase NMS.
That's great, thank you. And that's really helpful about the referral in terms of the signposting into those services as well, because it's, you know, that's certainly going to be welcome from our contractors. Can I just ask a few questions, Anna? I mean, unless anybody else has got any, but I can't see any hands up. I mean, just in terms of from a practical element, do the changes, they're in effect now, so community pharmacies will need to now start to drill down their stock practically of salbutamol and up, you know, maybe up their ordering of the Fobumix and the other changes that you've mentioned tonight as well. But so that's happened, that's in effect now. So clearly, you know, salbutamol, Salamol has always been a fast mover. So it's going to be quite a big change in terms of behaviour as well. So I guess that's just something to flag to community pharmacists and pharmacy teams tonight as well. Can I just ask around, well, a couple more questions actually. So is it something that's going across all practices as well? So there's no phased implementation of this, it's just happened and it's launched across all practices, or will there be a soft launch? Just thinking, because obviously if pharmacies are making the changes to their stock holding, they need to make sure that it's obviously being turned around.
So very good question, very difficult question to answer specifically, I'm afraid, but let me do my best. So first is that the guidelines are launched. Okay, so we're doing PLT events, we're doing a lot of training, education, webinars everywhere across LLR so LPT, UHL, and obviously primary care to adopt the guidelines. Okay, now will that mean that patients will be switched from one to another? If the patient's stable, they might not be changed. Okay, so I fear that some practices will take the opportunity to switch from Foster to Lufebec because of the cost savings. So I think if anything, you may start to see an increase in Lufebec. Obviously, we're very keen to use this as an opportunity to promote dry powders and better inhaler technique and MART and air therapy for our patients. But I think that element will probably be a slower phased, just by the fact that practices won't take it on board immediately, or they may for just new starters, and then some patients will be switched, but it will be a slower process. Okay, so it's not like from tomorrow everyone's going to be switched to Fobumix or everyone's going to be switched to, it's going to be during the practice. Likewise within UHL, if patients come in and they're on their Foster and they don't need it ordered, they're perhaps not under a respiratory consultant, we won't be necessarily changing. But if they are needing a new supply of their medicine, their inhaler, then we will use that as an opportunity to educate them and make that change. Okay, because that will help primary care out. So it is going to be a slow phase. Like you said, it's about it's that behavior change, and that's what we're going to probably see. And I'd love to see a massive reduction in your salbutamol, but I think again that will be slow over time. And of course, you've still got many of our COPD patients, children, things like that will still be needing salbutamol, but you may see a slight reduction. Well, I hope you will see a reduction over time in your ordering, but I can't see it being a massive overnight panic with everyone's on it type of thing and stock's a problem.
No, that's really good to hear actually, Anna, because I think, for community pharmacists, just making sure that from a practical element, they know what to do when they're going back in terms of their procurement arrangements as well.
Yeah, absolutely. Which is why I was keen to come tonight, because I know, that's so key.
Thank you. Nadia, you've got your hand up. Come on in.
Firstly, I wanted to say thank you, Anna. That was fantastic. It was really good for the insight, and it's also like a refresher as well for the asthma. So I really appreciate that.
My pleasure.
I just wanted to say that, and especially for the other contractors that probably experienced it as well, when the GPs get that message to switch, from my experience, they get a list of patients, and the switch is not, I won't say forced, but it happens very fast. And we don't ever have any insight as to when. So I guess it's that running down the stock of the Foster now, because otherwise you'll end up just holding it. So with these branded generics, they get a list of patients and they work down the list, and some patients push back, but in most cases, to be fair, it's just accepted. So I appreciate that there might be different approaches from the hospitals and But
Yeah.
I'd certainly, say to the other, take heed of Anna's advice on this chat and for the switches. Maybe not necessarily bulking up your orders on the Lofrebec or the Fubamex, but certainly running down your stock.
Yeah, I think you're absolutely right. And although we're not advocating that blanket switch, because I think that's where things go wrong, because patients then aren't really informed and things like that. We're trying to advocate it as a controlled shared decision making. But I've just seen a pig fly by my window just by even saying that. So I know, Nadia, exactly what you're saying. It's out of our controls, but I just wish they would, whatever we do, we try and promote that they speak to you, so you are aware of it. So any like the Salamol switch as part of our SOP for that, which we did promote, from Ventolin to Salamol, it was all around trying to make sure that you were aware that your Ventolin perhaps levels would go down, and also it's important because you're the ones that are going to often get the question, people saying, well, it's all about cost and I don't like this inhaler, why are they doing this? I know what it's like, and therefore you need to know
and
it's
I think
happening.
that's just wanted to thank you again, Anna, and obviously Rajvi, for organizing this and getting you here, because this is the insight that really makes a difference to our day to day. So
yeah,
these events and sharing this information.
No, it's my pleasure. I just find it very hard to only talk about asthma for 20 minutes.
I know. This is your
We
domain,
love
isn't
hearing
it?
you talk
about
about
this for
asthma,
weeks.
Anna.
I'll come back anytime.
Anna, I've just got one last question. I'm just conscious of time as well, if that's okay.
Of course.
Just to, and I think you kind of alluded to that in your answer to Nadia's comments and question. And your question was just around the counselling side, and you're right, community pharmacy will be probably picking up a lot of that. And I think, I guess, it's a two-sided question, is what's the expectation for community pharmacists and their teams with regards to the consultation? I know you talked about NMS and DMS, and that's great, but in just terms of the consultation, because that's unpaid activity for our contract for community pharmacy, and funny enough, tomorrow is a lights out campaign. So there's a you might be aware, I don't know if you picked it up, but there's potentially there's a protest that some community pharmacies will be participating, not all, including within LLR, where they'll put their lights out for 2 hours and wear black to raise awareness of the financial cuts, the strains under community pharmacy. So it's quite a dire situation, but I'm just thinking in terms of what's the expectation for community pharmacies with regards to the counselling aspect, and bearing in mind it's unpaid activity. I wondered if it's cost saving for the ICB, but actually from a community pharmacy perspective, it seems to be quite labour intensive, which is unpaid. And I know some other community pharmacies probably on the call would probably agree with me on that. And I wondered if the ICB had any, during your discussions about this, even maybe putting that into a service of its own kind, specifically to tackle the switching.
Yeah, this is maybe where I can invite Paul back in again as well, because I know Paul and I have discussed sort of trying to set up much better proactive paid services for community pharmacists, or even trying to utilize the new medicine service as a vehicle to support this, but almost using the community pharmacist to initiate the NMS rather than it always coming from the GP. The only thing I get it, I totally understand the expectations. I think I can't really have expectations as such, because like you say, this is unpaid if it's not part of a new medicine service. I think what we need to do is try and as much promote the new medicine service. If I can try and get the team here to do the discharge medicine service much more, at least then, I don't know if you've got capacity for all this, but at least you get an opportunity to take the payment if you do the work, which has to be a good thing. Again, like I said, this has got to be a shared decision making at the point of prescribing. We can't just expect community pharmacists to pick this up. This isn't at all the expectation. I guess what I was hoping, in the sense that I want to make it easier for you to, answer those questions when you're put on the spot, so it doesn't take a lot of time to do it, and you're able to support patients where you can. But you're right, these sort of things, it'd be much more effective if we had probably a paid service to actually support it. But that's not anything that probably the ICB is able to afford at the time.
Understand, and I think
I don't know if Paul's able to
it's a
come in
tricky
there.
question, and I know I understand the challenges behind it, but I'm just putting myself in the shoes of a community pharmacy.
I totally get it. Totally get it.
Paul, did you want to add anything? I don't know if you can.
Yeah, I think I'd add that from an ICB perspective, that for respiratory medicines, when there's an inhaler change, there is a service, which is the NMS service. It might not be perfect and do everything we want it to do, but that, my reasoning would be that there is a service in place. Now, whether we want something gold standard, something better to go on top of that, maybe we would. Funding is tight. It's a question of hanging on to what we've got. Sometimes for pharmacy, unfortunately, it doesn't even always happen, as we know. If someone's got a proposal that could work, now is the time of year to start thinking about that and bringing them, so that in the next cycle of financial year, we're armed. So if someone has got an idea about what a bolt on top of NMS service would look like and what it would do, I don't think, if you think in the millions, then it's not going to happen. But potentially come to us with an idea and what that would look like, but maximize the NMS. Look out for it. Every patient that we're talking about here, in my view, potentially can have an NMS.
Yeah,
but
absolutely.
I would also argue, and happy to go on record, that if they've tried a previous inhaler, right, for I would say, a couple, probably 2 issues, and switching back, that actually is that an NMS as well, because I think it's really important that these conversations with patients happen, and often they're not going to happen at the practice. So look for every opportunity to use to make use of the NMS service which is in place. We are a really good provider of NMS, both on quantity and quality in LLR. So let's leverage that, and please share the message. Look out for every opportunity. Work with work the practice, so that we have done some. We've probably not done as much engagement work around NMS as Pharmacy First with practices, but we have done engagement where we did run an NMS webinar. Practice pharmacists in particular are quite aware of it, but perhaps not always at the forefront of the mind. So do engage with the practice pharmacists and pharmacy technicians around how to sort of embed it when switches are changed, because they'll probably be leading on the switches, at least supervising them.
Brilliant.
And it would be worth reaching out if you've got those contacts to see what the practice's plans are in terms of the new guidelines, so you can then think about your stock as well and encourage that new medicine service. So it would be good to do that.
Brilliant. Thank you, Anna. Thanks, Paul.
Right.
Any other questions for Anna? And appreciate we've gone over, but actually I think it's been time well spent just to go through that level of detail and ask those questions. Anna, I just want to say, genuinely thank you for joining us this evening. It's been a pleasure. You're more than welcome to keep, continue to join us, but if you need to dash off, we totally understand as well.
Thank you so much. Thanks.
No, thank you, Anna. Thank you
very much.
You can share the slides with us.
I did send them across to you actually, so I'm happy for those to be sent out as a PDF. That's no problem.
That's wonderful. Thank you. We'll get that organised. Thanks, Anna.
Thank you. Bye-bye.
Thanks, everyone. Appreciate that's a really bad timekeeping on my part, so I am sorry in terms of chairing. Paul, should we go straight into you if that's okay?
Yeah, absolutely happy to. I will keep a pace. That's fine. Right. Okay. So good to see everybody. Right. Quick quiz. Answers in the chat. How many Pharmacy First clinical pathways consultations in LLR? So that's the 7 PGDs were done in February. Answers in the chat. Quick. First answer, right, okay, very good. Yes, 3,356, almost like you knew the answer. So yes, 3,356 PGD supplies were claimed for in February. Okay, so that's what you claim. So that's like the definitive amount, isn't it? Also, there were 4,208 minor illness referrals, which is actually a record. And that does include 111 though as well. And then urgent medicine 111, so 1,282. So just to give you a flavour of where we are, the data sets are starting to come, but they're still very spread out and disparate. A new one got released today that I've not looked at, might tell us a little bit more. But excellent, great news for a world of those pharmacy contractors living huge numbers. I do have the breakdown for services. It reflects a seasonal part, to be honest. So, like sore throats was I think that was the highest actually. But if people do want further detail, it's actually on the BSA website. It's open access, so you can see a little bit more detail on what you did and what your neighbour did, if you want, if that's interesting to you. Right, I thought I'd briefly talk about the medicine optimization framework that the medicines management team, the ICB, are launching at the moment. There are three probably key things that I think probably highlight to pharmacy contractors of particular relevance. One is a no rapid to true rapid switch continuing. So you probably need to do some stock management around that. No asks around community pharmacy, around counselling, other than what's in the essential part of that dispensing service spec. The second thing of interest is a practice medicines coordinator role. So each practice has been asked to appoint a non-clinical member of the team to take responsibility for repeat prescriptions. I'll come to a little summary of the role looks like in a bit. The third part is the Optum Accelerate, which is basically a simple cost-saving switch program. I have pushed the team for a list. I have said that as soon as it is basically in the public domain, it must be shared with the LPC for onward dissemination for contractors. I don't know what's in it. I don't know how many or what it looks like. As soon as it's in the public domain, practices don't know either yet. We will get that out to you. So again, you can do the effective stock management part. I'm not a fan of the branded generics personally, but the ICB is, let's be honest, strapped for cash, and it's an easy win, probably at the expense of community pharmacy contractors. I recognise that. I do make that point to colleagues. Unfortunately, that is the world we live in, where the whole, as I'm sure most people on this call agree, the whole reimbursement system is a shambles, and it needs restarting from scratch. Personal views there, not those of the ICB, just to clarify. But I think as soon as that list comes out, we will get that to you so you're aware of what's likely coming. Just a bit about the practice medicines coordinator. So there's 4 hours of training from Prescript. It's every practice has been asked to appoint somebody into that role. I think it's probably a key person to look to engage with around the problem solving, around the dispensing aspects moving forward. So I think give it a couple of months, then try to understand who the person is in your practices where most of your scripts come from, and really, perhaps meet with them, understand their role, build that relationship with them, and they'll absolutely be able to support you with the problem solving aspect of prescribing. Right, a quick message around post-event messaging. Firstly, around farm outcomes. If you're a farm outcomes user and you get this message after delivering a service that you cannot send an email, it is imperative that they are sent manually and then marked as manually sent. An issue has been identified where some messages aren't going through. It's currently being the solution is currently being worked up nationally around this, but at the moment, I know some people on here won't use farm outcomes, and some people here will always have a verified email address from a practice. There are 11 practices in LLR without a verified email address, and obviously those of you on the borders will also perhaps pick up from other systems, or if you deliver a service for a patient that's not registered in LLR, they may register a practice that's not got a verified email address in farm outcomes. If you see this, it must make sure that event notification goes to practice and is marked as manually sent. Apologies, I couldn't find a screenshot of that of that next part, but I'm sure most of you will be familiar with it. If you use one of the other 3 systems, I'm going to put my hand up and say, at the moment, I don't quite understand what that looks like for post-event messaging. I know where the email addresses come from. If you have a message that shows on your system that it's not been sent electronically, I don't know what that looks like or if it happens, but if it does, please can you mark them please can you send manually and mark them as sent. If you're struggling for a practice email address, send them email. We have got them all, just some of them aren't verified. Do get in touch with myself, and we'll look to share that list of unverified email addresses very imminently. However, we anticipate that we will push the final 11 over the line very shortly. I would expect further comms coming around nationally around this issue, but for now, if you see that yellow box, please send it and mark it as sent. Right, the emergency department, pharmacy first. I said referrals there. It was not a typo really. It's signposting using a leaflet. They are assuring me that they are diverting patients to pharmacy. I don't have a lot of evidence to support that assertion from them. I appreciate the controversiality. Is that a word? Anyway, of listing particular pharmacies on the front page, as it is very much as an interim measure to keep the ED department moving along. That they really were insistent that they had names that they could point to on a piece of paper. It was done. The basis it was done for on the list is based on the as the crow flies distance on the NHS website from the postcode of UHL. It's all around building up the market, the number of referrals from them. It's to create a new source of referrals for everybody. But we need to progress that bigger picture part. We needed to get them on board, and that's what they really wanted. Those of you who fed back to me, I have tried to respond individually. Happy for you to feed back to me again. That's absolutely fine. Do take it on board. There are they do a staggering amount of urgent repeat supplies where they actually take the patient in and do the prescription. All of those could go through pharmacy first. There is quite a big prize, I think, there eventually. So do perhaps bear with this, but understand the perhaps slight frustrations from some contractors that we did name some on the front page. IP pathway is progressing a bit very slowly nationally. Just to say that I've hopefully secured an additional one site for LLR taken from Northamptonshire. The condition of such was that it was geographically close to Northamptonshire. We've just gone out to pharmacy contractors who are in either Rutland County Council footprint or Harbour District footprint to see if there's any interest from those areas to participate in the IP Pathfinder. You will have details in your shared mailboxes, but absolutely ping me with any questions. That's absolutely fine. If we don't get a suitable site from those two districts, then I will go back to the regional team to see if we can expand it wider. But I have to see about that. Finally, around PCN engagement leads, this is just an update. It's been in the news recently. Each ICB has been allocated £1,000 per PCN for an engagement lead. The variety of different approaches from different ICBs. No one has confirmed quite what they're doing yet. In LLR, we're very keen that that person comes from the community pharmacy workforce and is neither a PCN individual or a ICB individual. That approach has now been supported in the ICB. However, we want PCNs to be involved in the decision of who is the lead. I haven't put it on a slide. We don't want one lead per PCN. We are going to insist on some grouping to provide some scale. The financial relationship will likely be between the ICB and the pharmacy contractees employees or contracts the individuals to do the role, but really keen that it comes from the community pharmacy network. There's probably a few internal ICB hurdles to jump through around the sign-off of this. We want people to work together to shape the priorities of that role, probably focusing on conception, hypertension and pharmacy first, and it's all going to be hopefully around legacy. The idea around the funding would be that as much of that £1,000 allocation will go to the individual who takes on the role. So whether that might be someone as a locum who wants to take it on as a role and it's just a locum fee. It doesn't have to be a pharmacist either, but wants someone from the community pharmacy workforce. It might be someone that you release, pharmacy contractor releases, but doesn't increase their hours. Obviously, that fee can then go to the pharmacy contractor if you've got spare capacity in your teams to release, or if you want to pay overtime for someone who wants to take it on potentially. It's still being worked up and around the KPI element of what we're asking for the role to deliver. other than the feedback very much led by LPC colleagues around what that role will look like, that absolutely be shaping that, I think, key. We're looking at, as well as providing an element of centralized support to the people that take the lead role on what organisation will be able to provide that support is still being worked up, whether it will be a lead PCN, a lead individual, or might even come and ask the LPC to see if they will be able to provide that, an element of that support with some of the funding, but it's still quite in draft at the moment. But and I think that's it for me. I'm happy if you put if Raj wants to push on. If you want to put any questions in the chat, I'll stay on and answer them.
It's
so
okay,
Raj has got
Paul.
an update.
It's okay, Paul. Don't worry. My update is very small. So if there are any questions, feel free to raise your hand or pop them in the chat really quickly. Any questions on what Paul's presented? No? Okay. Thank you, Paul. I'm just going to try and share my slides. Just moving on. So I'm going to keep mine really brief because I'm conscious it's now just gone past 9 o'clock. Just trying to. Okay, the first I'm going to keep it quite short and sweet, to be fair. The first really update was just around, just to remind our contractors that are joining us tonight, that our AGM has been announced. So the date will be on the 24th of September. This year it's an online event. So hopefully we'll get many of you joining. It's open to all our community pharmacy contractors and pharmacy team members. We're also thrilled to announce that we've got Dr. Layla Hambeck, Chief Exec for IPA, formerly known as AIM, joining us that evening. And the AGM theme this year will be survival instinct. And that's really for the reasons I don't really need to explain, but just in terms of some of the pressures that the sector is obviously facing, and not just across England, but many of our LLR contractors as well. So please do save the date, 24th of September. It's an evening event and it's online, and hope to see you there. The second thing that I just wanted to remind you, and probably the last thing I'll say before we leave for this evening, is just around the pharmacy advice audit. So this is really important. It's actually critical for us to do as a sector, because it's going to help CPE to gather critical evidence with regards to their ongoing call for asking for increased funding as part of the CPCF negotiations as well. So the deadline has been extended to Friday the 28th of June. So we've just got over a week to do that. I would encourage all our community pharmacists and LLR to participate in that, to get involved, so that therefore data that we give back is stronger and more accurate, and gives a better picture of what the dire landscape looks like for you. So this is your opportunity to feed that back in that given day through this audit. So Friday the 28th is the deadline for that. So I'm just going to stop sharing because I'm losing my voice, and also I'm very conscious of time. If you have any questions, feel free to ask. I'm going to stay on for a bit longer, or if you have any comments, please raise your hand. If not, I want to say a real big thank you for you joining this evening. I hope you've enjoyed June's open house surgery. Next month we'll bring another guest speaker from LLR to you, and that will be announced shortly. But thank you, and thanks for joining this evening. And the slides and presentation recording will be shared on our website shortly as well, hopefully by the end of the week. Thank you. Hey, can you stop recording for me?